So welcome everyone. Welcome to our Intimacy and Cancer webinar tonight. I just want to welcome everyone that has joined us this evening. And on behalf of Premier Health and our entire cancer team, I'd like to thank each of you for attending this evening. We are so glad to have all of you with us. So my name is Lori Scalise. I am the Oncology Service Line Director for Premier Health, and I will be your moderator for this evening. So before we get into our presentation, I'd like to give you a brief overview of cancer services here at Premier Health. Premier is the only certified member of MD Anderson Cancer Network in Southwest Ohio. This means that our local physicians have access to the expertise of the nation's leading cancer center, so we are privileged to be partnering with them. This brings two advanced cancer programs together to help you to care for you, our patients. So Premier Health offers cancer services at all of our hospital campuses. In addition to advanced medical oncology, radiation oncology, and surgical oncology treatments, we also offer a range of cancer survivorship programs, including massage therapy, nutrition counseling, support groups, exercise therapy, lymphedema, and other rehabilitation services, and more. So you can learn more about all of our comprehensive cancer services at premierhealth.com/cancer. So tonight, we are here to discuss the topic of intimacy and cancer. So we know cancer affects all areas of our lives, including sex and intimacy. Whether it is body image, treatment side effects, changes in your body, or other concerns, Premier Health wants you to know that you are not alone. We hear a lot of these concerns from our patients, so we're excited to be able to address some of your concerns this evening. Our speaker, I have the pleasure of introducing Dr. Celine Samuel, and our panelists, Beth Delaney, Joni Reeser, Alicia Slifer, will be sharing information and answering your questions on this important topic. So for the next hour and 15 minutes, we will hear a short presentation and then spend most of our time answering your anonymous questions. So to submit a question, click the Q&A button that is at the bottom of your screen, and then you can type in your question. All questions must be submitted through that Q&A button, and these will remain confidential. There will also be a chat button on your screen, but we wanted to make sure that you're aware that you need to disregard the chat button. So just make sure that you're clicking the Q&A button for any question submission. So feel free to send your questions throughout the presentation this evening, and we will try to get as many of your questions answered as possible tonight. So we will be recording this session to share with everyone later. So let's start off the evening by introducing our wonderful speaker. Dr. Celine Samuel is a fellowship-trained breast surgical oncologist at Premier Surgical Oncology. She is fellowship-trained at the Cleveland Clinic, Akron General Medical Center in Ohio. She also completed her general surgery residency at the University of Arizona and earned her medical degree from Indiana University School of Medicine. Dr. Samuel says, "My role as a breast surgical oncologist is to provide patient-centered treatment options that strive for a cure while restoring peace of mind and a return to a reasonable quality of life." So with that being said, welcome, Dr. Samuel. We are so glad to hear from you tonight, and I will turn it over to you.
Thank you, Lori, for that wonderful introduction. And thank you all for the opportunity to speak on this topic this evening. I hope that by the time we are done with this discussion, we all have increased knowledge and understanding about intimacy and cancer survivorship. Please start the presentation. So the objectives that I'd like us to kind of become more informed about tonight are understanding who cancer survivors are, knowing in the United States how many people have a history of cancer, also becoming more aware of the different types of cancer treatments along with the common side effects associated with these cancer treatments, understanding the relationship between cancer survival and access to care. Also understanding the different aspects of long-term survivorship, whether that be quality of life, financial hardship, or regaining the health of these patients after their cancer treatment through healthy behaviors. And lastly, understanding the intertwined relationship between intimacy, sexual issues, and the patient's cancer treatment. So who are the cancer survivors? So a cancer survivor is essentially any patient or individual who has a history of cancer and has been diagnosed and lived through that through the remainder of their life. And this can be anyone who's gone through their treatment and remains cancer-free. This can also be patients who live with cancer as a chronic disease, for example, lymphoma. And again, we have the other groups of patients who either experience a recurrence of their initial cancer, which was treated, or develop a different cancer in a different body organ. The number of people who do have cancer in the United States is estimated to be approximately 16.9 million as of January 1st, 2019. That number is expected to increase to more than 22.1 million as of January 1st, 2030. And this is thought to be secondary to the growth and aging of the population. However, these estimations do not take into account skin cancers such as basal cell carcinoma and squamous cell carcinoma. It also does not take into account carcinoma in situ, except that of the urinary bladder. So which are the more prevalent cancers? We have prostate, colorectal, and melanoma as the more prevalent cancers in males, and breast, uterine, and colorectal cancer as the more prevalent cancers in females. So types of cancer treatment can be individual standalone treatments, or it can be a number of treatments put together to help get that patient to cure or increase their overall survival. And we have localized treatment, which essentially is treatment to either remove the cancer locally from its site or slow down the growth of that cancer at its site. And those treatments are surgery, radiation, heat or chemical ablation, and even cryotherapy. Systemic treatments are more so treatments that go into the patient's body system. And these are typically medications in the form of chemotherapy, hormonal therapy, or immune therapy. We also have supportive treatment. So these are resources that are available to the patient that aid the patient in getting through their treatment side effects, or getting them to live in healthy lives while undergoing their cancer treatment or even after their cancer treatment. All right, so we talked about localized treatment, surgery being one of those. And there are side effects associated with undergoing surgery. Patients will develop pain, and they may have acute pain, which is pain immediately after surgery. And some patients may have chronic pain, which is pain that kind of is present weeks or months after their surgery. Patients can also develop seroma, which is a fluid collection at the site of the surgery. Depending on the type of surgery, patients can develop scarring, numbness, and tingling in the area of the surgery, and a change in the tissue sensation. Patients can also experience fatigue and weakness, and that's just part of the recovery from the surgery, and it depends on the load of surgery that the patient has to undergo. Another treatment for cancer is radiation. And certain cancers require radiation in part to keep the cancer from coming back after surgery. And certain cancers use radiation as part of the treatment of the cancer itself. Radiation can lead to skin changes such as peeling, redness, or darkening. It can lead to tissue fibrosis, which is essentially smaller and firmer tissue. Patients can also develop lymphedema secondary to surgery. And of course, fatigue. There's been no actual finding as to the direct correlation between fatigue and radiation. But this has been reported in multiple studies as something that patients do experience with undergoing their radiation treatments. And chemotherapy, another systemic treatment, has a multitude of side effects ranging from hair loss to neuropathy, memory loss, concentration problems, sex and fertility issues, diarrhea, constipation, mood changes, skin and nail changes. And honestly, it's because the way that chemotherapy works is it kills rapidly dividing cells, and cancer cells are rapidly dividing cells. And some of these cells, like your nerves, your skin, your nails, are also rapidly dividing cells that actually are affected by chemotherapy. However, in the long run, patients will experience either a return to normal or an improvement of their symptoms. There is a small number of patients whose symptoms sort of linger and actually affect their quality of life. So other types of medications or hormone suppressing medications, these are medications based on the tumor biology that is used to block that tumor from receiving the hormones that it needs to grow and spread. And some of these medications, such as tamoxifen, can cause vaginal dryness, weight gain, mood swings, hot flashes, depression, and even weakness in these patients. Another localized treatment for cancer is embolization or ablation. And these also have their side effects associated with them, whether it be bleeding if we're going through a blood vessel as a tunnel to get to the cancer in the intra-abdominal cavity. Patients can develop fever, nausea, abdominal pain, and sometimes other serious complications. All right, so when we talk about cancer survival, we typically look at the 5-year disease-free rate. And when we think of 5 years, we're thinking of the patient has been without a cancer recurrence for 5 years and ultimately achieved cure. When we look at all cancer types, colorectal, rectum, prostate, breast, lung, and we take all of those together, the overall survival rate is approximately 70%. However, when you take certain cancers such as breast and its early stage breast cancer, such as stage 1, the overall survival for that can be upwards of 90 to 100%. Now, achieving these high survival rates has really been substantial over the past few decades. And this has been secondary to factors that we can change, as well as factors that we have no control over. The factors that we have control over are those things that we are able to use as far as the patient's cancer treatment, and those things being the more up-to-date surgical methods, i.e. robotic surgery, chemotherapy, genetic testing, radiation treatment options, for instance, brachytherapy, a multidisciplinary team approach, which essentially is a team of different oncologists who come together and sort of decide based on up-to-date guidelines what the best recommendations are for a patient in undergoing their treatment for cancer. Now, some of the factors that cannot be changed are really factors that the patient presents with, such as age. It's something that can't change. But unfortunately, the age factor is kind of both ways. A younger patient who would present with cancer, typically younger patients present with more aggressive and more advanced cancers. And that's just something that we've seen across studies when young patients get certain types of cancers. On the other side, we have older patients who are presenting with cancers. And when they're presenting with these cancers, secondary to their comorbidities and health functioning, they may not be able to tolerate or undergo some of these standard treatment options, such as chemotherapy. The other things that can't be changed are at the stage at the time of the patient's presentation. Insurance status can also play a role in a patient's survival, and we'll talk more about that in a few slides. All right, how does cancer survival tie into access to care? Studies have shown, and it's been validated, that access to high quality of care increases the likelihood of survival. It also increases the quality of life for those patients. Lack of access to high quality care, unfortunately, can impact a patient's survival. And the lack of access to high quality care also results in disparities, where we see it in uninsured, underinsured, or ethnic minority groups. So who is a survivor? A cancer survivor is considered to be someone who has been diagnosed with cancer, gone through their treatment, and is now living through the remainder of their life. And how does the impact of cancer diagnosis affect the patient's survivorship? Cancer diagnosis can cause a multitude of things for patients. It can cause guilt, shame, and not just the patient experiencing these emotions. The spouse as well can undergo some of these experiences, the financial burdens for the cancer treatment. And that usually comes into play when there is a special treatment for the patient based on the immunology or biology of their tumor. And they may need a drug that may not necessarily be covered by insurance. And the patient may need to pay out of the pocket to get that treatment. Patients also experience a reduction or negative impact in their intimacy and sexual health after their cancer diagnosis. And so what is the survivorship issue when it comes to intimacy and sexual health? Men and women both have reported a complaint in experiencing sexual dysfunction after having undergone cancer treatment. The NIH estimates that approximately 40 to 100% of cancer survivors have a sexual problem after cancer treatment. Women will report sexual dysfunction ranging from approximately 30 to 100%. And men who do undergo treatment for genitourinary cancer will report sexual problems such as erectile dysfunction, loss of libido, or orgasmic dysfunction. And unfortunately, this is secondary to some of the treatments that they have undergone. And what are some of these treatments that can affect intimacy and sexual health? We already talked about localized treatments such as surgery. Surgery can create direct anatomic changes. For instance, patients who have a mastectomy essentially means removal of the entire breast tissue. Patients who also undergo pelvic surgery, whether that be for colorectal cancer or prostate cancer. And this in turn can lead to a disruption of body image. Patients who undergo colorectal cancer and need a diversion with an ostomy. And basically the colon or the small bowel is brought up to the abdominal wall, and that serves as their conduit for getting rid of feces and toxic material from the body. That can lead to a disruption of body image for that patient and negatively impact their intimacy and sexual health. Mastectomy, patients will lose sensation to the skin flap, or even sometimes if they undergo a nipple sparing mastectomy, they will lose sensation to the nipple and the areola complex. And lacking that sensation can influence how the patient sees their body. We've talked about chemotherapy, has multitude of side effects that influence intimacy and sexual health. Patients can develop erectile dysfunction, loss of libido, early menopause, hair loss, and this is hair loss all over. It's not just one area specific, and losing this hair can disrupt the patient's view of who they are. Radiation. We've talked about some of the changes associated with radiation. Leads to scarring of the tissue. Radiation to the breast leads to thickening of the breast tissue, hardening of the tissues. Radiation to the pelvic organs can also lead to thickening and hardening of the breast tissue, along with edema, which will resolve over time, but it's present and the patient is aware of this. So what is the overall physical effect of cancer treatment on sexuality? I haven't talked about the direct impacts of surgery, chemotherapy, and radiation, and the disruption of the body image and the physical structure of the body. It just changes the way that the patients see their body. Unfortunately, it also can change the way that the spouses see their partners who are undergoing cancer treatment. Patients may oftentimes see themselves as less of a woman or a man, depending on the organs that are removed, whether that be the breast, whether that be a pelvic organ. And patients may feel incomplete secondary to this. And unfortunately, it's sort of like a downward spiral. This also leads to patients being uncertain of their sexual attractiveness. And so there are ways as practitioners and as patients that we can discuss of how to get around some of the intimacy and sexual health issues. I think communication is key. Talking to the patient about it, asking the patient about it, educating the patient, even as providers, if we don't know the information due to our expertise being in a certain area, there are resources out there that we can direct patients to. And advising patients to alter their routine, and whether that alteration of routine may be just adjusting their time to when they feel less fatigued throughout the day. Practicing other methods of showing intimacy, such as caressing, massaging, hugging, and sometimes jokes really help lighten the mood as well. And just another slide to help patients sort of understand how to adjust the goal. If their old goals were previously being able to obtain an orgasm, having intercourse, then those goals can kind of change a little bit in understanding how to pleasure themselves without actually achieving orgasm, sensuality, a connectedness, playfulness, seductiveness. And I know that there is the American Association of Sexual Education that can provide information to patients about how to go about, with these new goals if they don't feel comfortable or don't know how to go about it. So long-term survivorship, there are multiple things that contribute to a patient's long-term survivorship. I wouldn't say they kind of contribute, they do contribute to a patient's long-term survivorship. And those are quality of life, financial hardship, and healthy behaviors after their cancer treatment. Quality of life can be broken out into three facets: the physical health for the patient, the social health, and the mental health. And the physical health, patients, it's important that they be able to return back to their physical functioning before their cancer treatment. And depending on the type of treatment that they received, at least get close to that physical functioning that they had prior to their cancer treatment. Having decent social interactions with the family, with their spouse, with their friends, also helps the patients long-term. And also assessing the patient's mental health. Patients do undergo anxiety, depression, psychological distress related to their diagnosis, as well as side effects of their treatment. This is an important part of the patient's well-being as well. And then also patients need to be aware that there are resources out there such as social services and nonprofit organizations that can provide financial assistance to patients who may develop financial hardship due to coping with their cancer diagnosis and treatment. Also, improving health through healthy behaviors by exercising, healthy eating, and returning to work. So that the patient is able to maintain some sort of physical functioning and also provide financial stability. So survivorship care continues even after the patient has reached their milestones of the 5-year survival rate and onwards. And this is when the patient and their provider work hand in hand to prevent new and recurrent cancers and the late effects of treatment. Also undergoing screening and surveillance for subsequent primary cancers, and also assessing the patient for any effects that impact their psychosocial or physical well-being. There are several resources for patients to get help and for providers to know where to send their patients for help. Patients should feel free definitely to speak with their providers if they're experiencing any of those side effects or, symptoms that were discussed earlier in the earlier slides. We have social worker who, if we don't have the answer, the social worker is always a very good resource in helping direct the patient and assessing their needs and seeing what we can do to get the patients the help they need. We also have counselors and psychologists, sex therapists, as well as physical therapists who work with the patient day in and day out to get them back to their baseline physical functioning. Next slide. So I want to say thank you so much. I hope that we were all able to gain some knowledge and understanding regarding intimacy and cancer survivorship following this presentation.
Okay, thank you so much, Dr. Samuel, for that informative presentation. And next, we are going to spend the rest of our time together this evening answering your questions. And I just wanted to remind everyone, if you'd like to ask any questions, please feel free to do so now and use the Q&A link at the bottom of your screen. So I'm going to introduce the panel. So joining Dr. Samuel for this evening on the panel Q&A is Beth Delaney, Joni Reeser, and Alicia Slifer. So Beth has a Doctor of Nursing practice and is a family nurse practitioner who focuses on cancer survivorship care along with additional areas at Dayton Physicians Network. Joni has her Master's of Science in Nursing and is an acute care nurse practitioner at Premier Health Urology in Troy, Ohio. Alicia has her Master's of Science in Nursing and is a nurse practitioner at the Premier Health Gynecologic Oncology Clinic at Miami Valley Hospital South in Centerville. So welcome to all of our panelists. So while our attendees are continuing to send their question in, I'm going to go ahead and we've got several questions coming in. So I'm going to start with Dr. Samuel. I'm going to address this one to you. Do you recommend therapy to help with communication about intimacy issues, especially when one spouse or partner is no longer feels comfortable with any form of intimacy?
I highly recommend therapy, yes, because a therapist is a specialist that understands this and can get to getting the spouse and the patient to actually communicate where that barrier is and them achieving intimacy and sexual health.
Okay, thank you. Beth, did you have anything else to say on that? I saw you shaking your head.
And like Dr. Samuel, thank you for your great presentation. When it comes to therapy, I think what Dr. Samuel said in her presentation about being prepared ahead of time. And when you said that, Lori, what I was thinking about the numerous couples that I've worked with, and what we have to remember is we aren't all the same. And so not only do we bring our own personalities to these interactions, but sometimes some historical things that have come. So as human beings, some of us are more mental and spiritual, and we bring that to intimacy reactions. Some of us are more physical, and we bring that to intimacy interactions. And many of us, I would say most of us, have some kind of things in our path, grief, trauma. And so what I've learned in over 30 years of caring for people with cancer is in those interactions of intimacy, a lot of that comes with you. So helping a person through therapy, helping people understand that this is really common to have all of these thoughts and feelings. And if you haven't, maybe, like, it's not everybody's expertise to be excellent communicators. So don't be a hater on yourself. It's okay. We can all learn if we're willing. And so I cannot stress enough in my clinic about talking to patients at the time we're making a diagnosis, as we're choosing therapies, how important getting with those people that you love so much to start that communication and help it to be open. And if communication is not your thing, then get some help. I'm totally with you. Yes, yes, and yes.
Thank you, Beth. I could listen to you all day. Thank you very
My
much.
husband would say, no way, Lori.
Yeah. Okay, I have another question. I'm going to open it up to the panel of whoever would like to address this. Are there any medications that can help improve libido lost as a result of a cancer diagnosis? Anyone? Dr. Samuel?
Well, I would maybe say that depends on why they have a loss of libido. I think that's what you have to address first, because sometimes the loss is more of a mental or emotional issue. Sometimes it is a physical issue. If it is more of, is depression a part of this, is something like that, then there might be some. I found some patients that Wellbutrin has worked really well for, and things like that. Is it, sometimes it's a menopausal issue, and there's mood swings that are going on as well, especially in our younger patients that have maybe been put into menopause a little early. And this is all coming on really quickly. And there are some medications, non-hormonal, in our patient population. Oftentimes we can't use hormones. So we do look to things like the SSRIs and SSNRIs, Effexor, and things like that. So there can be some things that might be able to help if, depending on the issue. If it is a more of a physical, an anatomical issue, some of our patients have had some extensive surgeries, especially externally to the vulva and things like that. That starts to get a little bit more difficult. And we try and find resources or ways that they might be able to bring back some of those things with their partners. But it is a little more challenging because unfortunately there isn't always just a medication or a pill that we can give. There are sometimes over-the-counter things, vaginal moisturizers or things like that, depending on, is that a potential issue? Your fear going into it is such that I don't want to do this because I know it's not going to be comfortable. And so therefore you kind of have just this general loss of libido. So I would say, I don't think that it's not necessarily an easy answer. Like, yes, there's a medication, but I would say, yes, there are options for you out there. We just have to talk through them.
Okay. Thank you, Alicia.
Yeah, I agree with that. I think understanding the etiology. And one thing that people don't know about physical therapies, there are physical therapists that are highly trained in different body parts, and there are physical therapists that are trained in the pelvic region. So if a patient has substantial scarring in the vagina or in the anal vault, there are physical therapists who are trained to provide massagings to those areas to help those patients kind of overcome the barrier to why they're unable to achieve some of those things already mentioned related to their sexual health.
And I agree with what Alicia, both of you said. And when Alicia said about, especially if you've been having intercourse and there has been a dry vagina, and then that has happened and it's painful, it's difficult to get that image out of your mind sometimes. So being worried about repeating that discomfort is another thing that sometimes needs to be overcome. So there are ways that we can do that. And so again, back to making sure that people are talking openly with their providers so that we know how to help is really important.
Okay.
One
thank
thing
you.
one thing that I would like to add is people always will go to the internet and search and try to find something that can help them. So depending on your cancer diagnosis, I work a lot with men with prostate cancer. You just got to really be careful that you're not taking supplements that have testosterone base, because that is what feeds, unfortunately, prostate cancer. Now, when you get to a certain stage in your treatment on down the road, sometimes we can start to introduce testosterone therapy with you, but that needs to be watched closely with your provider. So just watch the supplements that you take, but eating healthy, a very healthy diet, that will help with your energy, that will help with, your well-being, and that in turn will help with your libido and your desire.
Okay, thank you for that. I have another question from one of the folks that have attended. So this one is for you, Joni. What is the impact of testicular cancer on the ability to father children?
That one, again, is going to be dependent on how far out from your treatment you are, what type of treatment that you went through, whether it's an orchiectomy where they remove the testicle, whether they've given you the chemotherapy in addition to that, and the spread. Dr. Samuel, would you add anything else into that?
No, I think you spoke factually on that. It really depends on the extent of the surgery, whether or not it was one testicle or both testicles removed, unfortunately. And patients can actually have that conversation with their medical oncologist if they decide, and this is for female patients too, if you intend to undergo, or not that you intend, not because you don't really want to, but if part of your treatment algorithm means that you have to get chemotherapy and your future plans involve having offspring, then you should have that conversation with your medical oncologist and say, hey, I want to have kids in the future. How do I go about whether it's storing my sperm or storing my eggs? And that's an option. And you can get a referral to a fertility specialist about how to go about that. Unfortunately, time is of the essence. There are patients who don't have that ability, because maybe it's going to take 4 weeks or 6 weeks to get in to see the fertility specialist. And based on their stage at the time of their diagnosis, the treatment sort of needs to be started immediately. And then those are the patients where you sort of weigh your options and decide, okay, I'll go ahead with my treatment. I would not recommend putting off the treatment, because if the disease is advanced, then there's probably no thought or opportunity for fathering offspring in the future, and just proceed with your treatments. And then, as Joni mentioned, years down the line, the body does recover, and actually seeing what are the improvements as far as fertility.
Okay, you actually have just addressed another question that came in, and it was about freezing eggs or sperm. So I think that is answering that question there. So thank you both for that. Okay, so Alicia, I have a question for you. This particular person says, I have incontinence as a result of cancer treatment. I am afraid to engage in sex for fear of having an accident. Is there something I can do to avoid accidents?
Absolutely. Absolutely. And a lot of that, again, it depends on where are you at in your treatment. We see this just at the beginning, maybe after your extensive hysterectomy and staging surgery. And sometimes it's just a matter of recovering from that. A lot of times with radiation, we will see longer term effects in the bowel and the bladder. In that case, there are exercises, bladder retraining tools that we usually will try and start with. Urology referrals are always important, because we do like to fully understand why are you having this incontinence, and just making sure that the health of the bladder is intact. After certain treatments, radiation especially, you can develop things called radiation cystitis that can cause just some kind of inflammation that comes and goes, and it's a matter of trying to figure out what is causing this and things like that. Again, going back though to Dr. Samuel, the pelvic floor therapy is such a important and I think relatively new and upcoming form of therapy. And I'm seeing more therapists, younger therapists, actually starting to get excited about this field. And that's just a really, really great way to identify what in the pelvic floor could be causing this. It could be weakness. It could be the scarring. It could be that the pelvic floor is really tight. And they are really great at first evaluating what are the causes of that, and then helping to treat. It's one of those things you have to invest some time in. You know, as with all therapy, if it's joint therapy, you know, it's a matter of going and doing it and putting the work in. But I've had patients that have had really, really great success with pelvic floor therapy. There are always some medications too, but again, we usually defer that to the urologist, because at that point they've kind of identified, is this something that we can help with various apparatus like a pessary, or is there a medication that we can give? But certainly incontinence is probably one of the biggest things we see, and depending on what the cause is, we can certainly usually address it and make really good improvements in that area. So yeah, discuss that issue with your provider for sure.
One thing that I always add from a male standpoint is with prostate cancer, if you choose a treatment with your provider for prostatectomy, initially you'll have a catheter in place. Then when the catheter comes out, you will experience some incontinence. Generally, over time, that gets better. They do recommend like the use of a vacuum pump, which does a couple of different things. One, it helps with the muscles to reestablish the strength of the muscles down in the pelvis. And it also eventually will help with erectile dysfunction as well. Some simple things that you can do are just go to the bathroom before intercourse and after intercourse. Keep your bladder empty. That's one easy way to help with decreasing, you know, and watching like the fluid intake right before intercourse, because you don't want to get the kidneys to produce extra fluid to increase your bladder volume. And then like Alicia was saying, there is some medications that can be used. Physical floor therapy is a great option as well.
Okay. Thank you for that. I have another question that just came in for Dr. Samuels. I am 6 years post BCA diagnosed with double mastectomy, chemo, and radiation treatment, taxoxifene for 2 years, and now on, oh, I'm not going to be able to pronounce this, anastrozole. That's it. Intercourse is very painful to the point where I am unable to perform or enjoy much of this. It's hard for me and my spouse. As my BCA was hormone positive, what are my options to help this issue? Are there non-hormonal type of meds?
So congratulations on meeting and surpassing your 5-year survivor rate and now being cancer-free approximately 6 years. So the hormone suppressing medications, it used to be that patients could take that for approximately 5 years, and depending on the patient's life expectancy, et cetera, patients can actually take this for up to 10 years. There are multiple options for post-menopause. And if you're having side effects that are barring you from being who you used to be before you underwent your treatment, or just having fun and living life, definitely talk to your medical oncologist and say, hey, look, this medication is not allowing me to do the things that I enjoy, that make me who I am and make me the partner that I am for my spouse and with my spouse, and see what are the other options. Unfortunately, the side effects associated with the variety of medications, there are about 4 hormonal blockers, can prevent patients from actually being on some of those other options. So I would say, you know, it's a risk benefit. Some of those medications actually cause osteoporosis. And if you've got a low bone density, then that medication is not necessarily an option for you. You can't do progesterone creams. I tell my patients all the time, you got to get off of it. I have patients who show up and they're on supplements because it increases their libido and it helps with vaginal lubrication because it is providing the hormones that we naturally have that do those for us. And I say, don't do it because the cancer is going to come back if you had a hormone positive cancer. And at this point, I would strongly suggest talking to your medical oncologist. They know what resources are out there. KY jelly is an option. Seeing a sex therapist is an option. And there are sex therapists out there who are well versed about cancers. And they know which supplements are good depending on the type of cancer a patient has and the medication that they're using to treat those cancers. So I would highly recommend speaking with your medical oncologist and getting a referral to a specialist.
Additionally, in Survivorship Clinic, when it comes to those over-the-counter, what Dr. Samuel said, agree with 100%. And what she finished with was talking to your provider. That's critical because anything that we say to you tonight, you have to talk with your provider about. Don't just go do something without talking to your provider. That's probably not in your best interest. But this is something that I talk about regularly with patients. And so there are 3 over-the-counter options that are non-hormonal that we discuss and use in our survivorship care plan. Like Dr. Samuel said, KY jelly is what I usually start with. But even before that is about American Cancer Society has a booklet called Sex and the Woman with Cancer, Sex and the Man with Cancer. And I usually start with this because I say to the patients, yes, I understand that it looks like a 6th grade health class, but we all have to get on the same place as far as the diagrams that are in the literature and in the book. But what it does is talks about ways to educate both the patient and the provider about ways to maximize foreplay and maximize ways to stimulate and to go. Maybe part of the issue could just be going a little bit slower and having maximum time for foreplay. So that first is education. Next, KY jelly and being comfortable literally with using KY jelly. After that, there's a product over the counter called Astro Glide. Funny sidebar. It was created by a NASA lubricant specialist. I've tried to read more about it, but that's just your fun fact from this tonight. But Astro Glide has a whole set of products that do not contain any hormones. So you want to make sure that you're buying no hormone products. And then the responses that I've heard from patients about Astro Glide is just a little bit thicker than KY jelly. And you can try Astro Glide. Simultaneously, there's a product called Replens. Replens is like vagina lotion, basically. No, again, you want to avoid anything that has any kind of hormone in it. But Replens is like a vagina lotion. It comes in suppository and it comes also in like a gel. And so what I tell all of my patients about all of these things is don't forget you can become irritated from these products also. So you want to just be sure that you go slow. You talk with the provider about how you're using it. And Replens basically is a product that you can use. I bet Alicia uses Replens and talks about Replens regularly. You can use it once a week, twice a week, more than that. And it's really just a way to put moisture back into the vagina. And so it's like putting hand lotion on. And so again, you have to decide if the product is helpful, is it irritant, and then please talk with your provider. Alicia, do you have anything else to add? Did I miss anything?
No, actually, that was spot on about the Replens. I was glad that you brought that up because yes, that is a huge product that we talk about and discuss, and that our patients, when especially used properly, does help. Like you said, it's something that you use multiple times a week. You think of it like a lotion. If you've got dry, chapped skin, you want to use that regularly, daily, whatever, so that you maintain the health of that skin. And it's that same thought process with the vaginal tissue, is that you're trying to maintain instead of just a one-time lubrication like the KY jelly. So Replens is great, and we have a lot of patients that use it and have a lot of benefit out of it. Absolutely.
And if you use Replens at the time of intimacy, then you can still use KY or Astro Glide at the time that you're having more intimate
Yes.
contact.
Yep.
Okay, thank you. I have another question for Dr. Samuel.
Hey, Lori,
Yes.
I'm sorry to interrupt. There's just one other thing that I would add to what Beth and Alicia and Dr. Samuel is saying. And that is for people not to be afraid to look outside of what they've done in the past to help with the experience. So as an example, sex toys, using like a finger vibrator, using like a bullet, that helps make the tissue healthy. It helps stretch the tissue. It can be used with the Replens or with the KY jelly just to provide the extra foreplay that can make it more comfortable, plus also changing positions. If you're used to being in one position and now it's uncomfortable, you might just need to try a couple of different ways, and that can make it, more pleasurable as well.
Okay, thank you, Joni. I have one for you, Dr. Samuel, I just received. Let me see if I can find it here. Okay, so Dr. Samuel, I've heard that with breast cancer, getting all the breast tissue out is the best way to prevent it from coming back. Does nipple sparing surgery increase my risk for reoccurrence? Also, does nipple sparing surgery help retain complete feeling?
All right, so having a mastectomy decreases the chances of the cancer coming back. It does not make it zero. Okay, it can decrease it to up to 90%. And that other 10 to 5% is really because of the way that the breast tissue grows into the skin that it is underneath. And it's absolutely almost impossible for the surgeon at the time of your mastectomy to scrape all those breast tissue out. If they do, they're getting into what we call the subcutaneous tissue. And that subcutaneous tissue contains the blood supply to the skin. And that's when we see issues with flap necrosis, meaning that the skin dies. So having a mastectomy does not make your chances of getting breast cancer in the future 0%, but it will significantly decrease it. And studies have shown that lumpectomy with radiation and mastectomy have about the same rate of disease-free survival and overall survival. I think that when patients choose to undergo mastectomy, patients will always ask me, well, what would you do? And I said, well, I'm not you. My lifestyle is different from yours. My expectations are different from yours. And my ability to cope with some things are different from your ability to cope with those similar things. If you feel that after your breast cancer treatment, it's gonna drive you up the wall to go get that screening mammogram, and you're gonna be sweating and anxious and about to pass out because you're concerned about what they're gonna find this time, then perhaps you should just proceed with a mastectomy, because you might just have a heart attack or develop anxiety and depression and need to be on medications lifelong. And then there are the patients who have a genetic mutation, such as the BRCA gene mutation, the CHEK2 gene mutation. And these are mutations that, firstly, they increase the woman's risk of having breast cancer in the first place. And after having had that first breast cancer incidence, they have another risk of getting breast cancer in their lifetime. So a 40-year-old with a BRCA gene mutation and breast cancer would highly likely benefit from undergoing a double mastectomy, because she's got another 40 to 50 years of her lifetime remaining. And with that gene, she has an increased risk of having breast cancer again. And so those are typically the patients that I would recommend to proceed with a mastectomy. But otherwise, lumpectomy with radiation, same overall survival, disease-free survival in comparison to mastectomy.
Great, thank you.
You're welcome.
Beth, so here's another question for you. Do you have any suggestions on how to introduce the idea of body changes as a result of cancer treatment, especially when you're just dating people?
This question came up in my clinic today.
Wow. Okay.
And so, and interesting, in preparation for this particular time together, I listened to some extra podcasts, and I thought, so just sidebar, cancer.net, which is the American Society of Clinical Oncology's patient education site, which I know that all of us on this call use. So we would use cancer.net, cancer.org, cancer.gov. They have a podcast series that has these short little blurbs, and 2 of them were on sexuality. And well, the way that I liked the way that they described this, and they talked about if you're in a relationship with someone, it depends on the level of relationship that you are with that person as to how much you're going to tell them about whatever that you're thinking. And so I know I've said 2 other times tonight that communication is critical, but what you have to do is feel comfortable about what you want the other person to know about you. And so if you are having a relationship where it's growing and things are becoming a little more serious, then you don't have to, and kind of maybe share a little bit of time. You don't have to, if it's up to you, but go on the first dinner date at dinner at the appetizer and tell them everything. And so again, it's about how you feel about this person. What do you think that your relationship will be like? And then really, it's the old truth, honesty is the best policy. And back to what I was saying earlier about trauma and difficulty, sometimes that's going to be easier, way easier said than done. And so I would probably, when I talk and counsel with my patients, I try to ask them a question of, first, how close are you to this person? Are you close enough to this person that you want them to know your story? So that's number 1. Number 2, what are you afraid of? Like, are you afraid that they will run away if you do tell the whole story? And if they do, then you have to decide, if their reaction's running away, what do you think about that? And so really, it's not a answer, like back to earlier when we were talking about a pill for libido. This is the same thing. It's really about growing a relationship, gauging what you feel comfortable sharing, asking good questions. What I've learned also in the world of being a palliative care nurse is asking questions of the other person to help you understand what they're thinking, which might give you insight into how you think and feel moving forward. And so another thing that's another good provider question. And if you are in counseling, like we kind of suggested earlier, maybe if you are thinking about getting serious with a person, you could dialogue and role play with someone that you trust, or maybe that therapist, or maybe that your provider, or advanced practice nurses. We take a lot of questions like that. We have a lot of dialogues about that. And so we'd be happy to look further. Maybe also think through, if you were the receiver of what you were going to say, what questions will be going through your mind? So maybe you offer that information up at the beginning, again, in ways that you feel comfortable sharing at the pace that you feel comfortable sharing it. Lori, did that answer the question?
I think so. Thank you.
I would probably also say it's important, I think, for the patients to understand, or I don't understand, but to know what is it that they're actually worried about. Sometimes they think that it's worse than it actually is. We have a lot of patients that have a hysterectomy, and they think because they lost their uterus or their cervix, sex is automatically going to be maybe not great for them, but that their partner is going to be able to tell. And that's really not the case. I think most men wouldn't know the difference if a woman had just had a hysterectomy, has her cervix or doesn't. And it's sometimes just educating the patient. So what is it that you're afraid of? And then let's talk about that, because it may not be as bad as you think it is. sometimes there are visual, like anatomical things that are different. And we might give the patient a mirror while they're in their exam and just say, what in particular are you worried about? Or are there, in our vulvectomies especially, that can be, that could be something that people are really worried about going into. My partner's going to see this and they're going to know that I've got scarring or that I've got changes down there. And so you talk to them and show them ways to maybe not normalize it, but to let somebody else understand this happened, but I can still, I can still function. This is not necessarily going to change anything, and being confident that, you can still have a meaningful relationship with someone. You don't need to kind of kowtow to them on a date or anytime in your relationship to say, well, this happened to me and I'm ashamed. This happened to me, but I'm through it and I continue to work on it. And I can have a meaningful relationship, even though this happened to me. So you have those discussions with our patients as well, so that, they understand it. They might sometimes be building things up in their head more than, than what's really going on.
I'm going to piggyback on something that Alicia mentioned regarding scars for breast cancer surgery. I think something that patients should be aware of that they might not know is there's something called a hidden scar method, and you can ask your surgeon about it. Can they utilize the hidden scar method in treating your breast cancer? I try to do that in most cases for my patients. For instance, upper inner breast cancers, right? Cancers that are right here. No, I don't want to put an incision here, because in the future, then whenever she wears a tank top or nice dress or attends a wedding, everybody knows that she underwent some sort of surgery. For cancers that are in the upper inner quadrant, I typically will place my incisions around the areola and tunnel up. Depending on the cancer that's in the outer breast, we can also place our incisions more laterally so that they are not visible, especially when a woman desires to be intimate. And also in the inframammary region, and that's just underneath the breast. We use that for some nipple sparing mastectomies, and we can use that same incision for some lower quadrant breast incisions, breast cancers, or just breast masses that need to come out. So that's something that you can discuss with your surgeon as well prior to surgery.
Okay, so we have time for 2 more questions and then we'll have to wrap it up. So I've got sort of a 2-part question here, and this is to Beth or anyone on the panel. It sounds like sexual issues can get better over time after cancer treatment. Should I just wait out my issues and hope that they get better? And then I'll give you the second part of the question after you answer that.
Someone else can go first if you like.
I would say that it's very important to talk to your provider. Don't be afraid to say how you're feeling. Get that discussion started as soon as possible so that, we can help you make some decisions or refer you to a physical or a therapist, help you make those decisions earlier, because the earlier you ask it, the more comfortable you'll be as time goes by. So don't be afraid to just ask right away.
Well, sometimes what you do on the front end of things too is what's going to make things better later on. For patients that had radiation, starting that vaginal dilator early, using that, especially as much as possible in that first 6 months, is what's going to make things easier for you later on. So there are some things that waiting out is not. What you do up front is actually what's going to help you later on.
Okay, so the other question to follow up that, what is the best way to find a therapist to address sexual issues within a couple? What is the first step and where do I look?
So I concur, and I'm thinking, Dr. Samuel, we make that unanimous, don't wait. Like because of fibrosis, because of scarring. So I think Joni and Alicia, we're talking about physical, but I would also say that the emotional and spiritual issues don't improve. Like I would say, get working on those sooner than later. So what I usually do is I have great collaborators, and Dr. Samuel said earlier, that are social workers. And so when I refer a person, which I do almost, well, let's talk about that. When I talk to people in clinic and I get done with an initial survivorship visit, I help them understand, or try to help them understand, that emotional and mental health issues, thoughts of being overwhelmed, thoughts of everything that's happened, reflecting on back, are very common. So when I read through common survivorship concerns with people, emotional and mental health is at the top. And so I regularly let patients know that I send about half of my initial patients, I'm just meeting them for the first time, for short-term mental health process counseling. And when I explain it to them that way, especially with if they've had trauma or grief or abuse in their past, and now they have this diagnosis of a cancer, it can really stir things up and they kind of are caught off guard. So sending people to mental health counseling, whether it's for sexual issues, for mental issues, for spiritual issues, all start with, from my perspective, collaborating with a social worker, because the social worker has the expertise to look at insurance coverage and what options are available. At Premier Health, in some of our locations, we have social workers that are also counselors, and sometimes they can do a couple of free visits, which being aware of financial issues is important. So maybe it's something where we can get a connection to an internal social worker that can help. But also then maybe the social worker can look at the insurance coverage, look at where the patient lives, look at, and just help them select, and or come back to me and say, hey, do you know these names, or do you know someone in this area? So what we try to do is make that match, because I'm hoping that, number one, and this is like, something that I don't know if the people would agree with me on the call, when you get into a mental health counseling, that can be so useful and so helpful. So I try to educate my patients to say, you know, sometimes there needs to be a connection. So if you go a couple of times and you don't feel a connection with the person that you feel like you can share, maybe we just haven't made that right connection. So that's really important. And I think that'd be really important for if you're going into couples counseling, counseling about sexual things. So having a connection, and then also trying to be honest with the counselor. These are hard, difficult things. I don't want you to share or be traumatized when you're working with that person, but I do want you to know that the quicker that you feel honest about what's happening with the counselor, my experience is the quicker that you're going to get some tangible, helpful outcomes and coping mechanisms from that interaction. So for me, helping find that partner, that's the social worker that can either do some baseline quick, I say, or short-term counseling, or help look at what's available, look at what's the insurance coverage, and then kind of move from there.
Yeah, the bottom line is, as the patient, you're not expected to, how do I find a therapist? How do I go about doing that? We're here to help you do that. You need to speak with your provider and say, this is an issue, and then let us help facilitate that for you, because that's what survivorship is about. It's the physical, it's the mental, it's the emotional, it's everything that comes with what happens once you have a cancer diagnosis. And there are many things, areas in survivorship where we want to help facilitate that, whether it's physical therapy or it's counseling or it's exercise, afterwards, or it's nutrition, or all of those things. The bottom line is always, you're not expected to figure out, who do I go see for this? What do I do? You need to talk to your provider and then let us help facilitate those things for you. It's what we're here for.
The other thing that I usually will tell people too is to write down on a piece of paper what it is that's important to you, or what is your question that you would like to have answered. Whether male, female, everybody has their own expectations and their own thing that is important to them. When you go somewhere, sometimes you'll feel scared, you'll feel shy, you'll feel like, that it might not be important to the other person, but it is. So don't be afraid to write it down on paper, take the paper with you. They'll answer questions, they'll give you suggestions. And then if your answer hasn't been met, then don't hesitate to say, hey, here's an issue I have.
Okay, so we actually have another question for Dr. Samuel. I am a 10-year breast cancer survivor with a double mastectomy and significant radiation burns.
Ooh.
I have trouble looking at myself in the mirror. Is there anything else I can do at this point, or is it too late to make body changes?
So congratulations again on being a survivor. Unfortunately, that is some of the side effect associated with radiation. And this is, here are options. So this is what I tell my patients who are undergoing radiation treatment. Put aloe vera or cocoa butter, some sort of ointment that moisturizes on your skin at least an hour before your treatment starts. You can't put it on 10 minutes before your treatment because it kind of coats the skin and doesn't allow the radiation beams to actually get to the area that needs to be treated. Unfortunately, guess what? Radiation, and this is the best way I can simplify it and help my patients understand, whole breast radiation, even after mastectomy, is like smoking meat. You go from something that's nice, juicy, to something that kind of feels like beef jerky. It's drier, it's not as pliable. Recommendations, number one, I'd say physical therapy. Meet with a physical therapist. They can do some massaging to kind of soften up that tissue and also teach you what you can do to soften up that tissue. Second, lather up. Cocoa butter is never too late. I've seen improvement from cocoa butter years after treatment because it really just works that well with wound healing and protecting the skin and kind of rejuvenating new skin cells from underneath. Aloe vera is also pretty good. And if you're not seeing any improvements, then get your primary care doctor to refer you to a dermatologist. And you want to go see a dermatologist that's not just a cosmetic dermatologist, right? You don't want to see someone that's only dealing with pimples, like Dr. Pimple Popper. You want to see someone who kind of treats a variety of skin conditions and has experience in also treating cancer patients who have undergone radiation treatment, because there are medications out there that can help, and prescriptions out there that can help soften up that tissue.
Thank you, Dr. Samuel.
You're
So
so
we are running out of time, and I wanted to thank everyone for joining us this evening, and all of our providers for sharing their knowledge and expertise with us. We really hope that you have found the information shared tonight very useful. We feel very privileged to be with you this evening and hope that you consider us for any of your healthcare needs. I would like to let everyone know, please help us honor all of our cancer survivors. We have many of them on the call with us tonight. We are creating our second Tree of Life photo collage to celebrate Cancer Survivor Month. So we are asking folks to send in your photo to add to the collage, and when assembled, it will be shared on social media, our website, and in our cancer centers. So please submit your photo online to premierhealth.com/tree of life. And there are only a few days left to submit those photos. We also wanted to let you know that there is a follow-up email that you will be receiving a quick survey about tonight's presentation. We did record it, so that link will be shared with you as well, so you could actually share with others or family members. So thank you in advance for taking time to fill out the survey. We really thank you for helping us celebrate cancer survivors, and that includes you. So with that, we wish you all a great evening, and thank you so much for attending tonight and all of our speakers. Thank you so much. Take care.